Welcome, everybody. I am Terry McGovern. I'm the chair of the Heilbronn Department of Population and Family Health, and I'm also director of a program called Global Health Justice and Governance. We have together been kind of sponsoring a bunch of discussions on equitable distribution of vaccines. We've had some amazing conversations global, a lot about vaccine distrust, historical racism, and I'm really excited about today's discussion, which is COVID-19 vaccination and incarcerated populations. Chelsea Clinton and I were discussing the importance and how much students were also interested in this topic. So we have an amazing set of panelists today, really an impressive group. I just want to say a bit about my history. I actually founded something called the HIV Law Project in 1989 and worked a lot with incarcerated populations. And so much of what I'm seeing in COVID reminds me of what we saw in HIV, which was converging epidemics and a lack of attention to kind of these converging epidemics. And in fact, it was women with HIV incarcerated at Bedford Hills and in California who were the ones who first called out that the AIDS definition was based on white gay men primarily, and that there was a problem with it. We ended up successfully litigating, and the numbers went up in New York 58% among communities of color. So I have many kind of memories flooding me constantly in this current situation, and I think we can count on. Despite the many obstacles, a lot of really incredibly creative stuff coming out of our incarcerated populations during this time. So just before I turn it over to Chelsea and actually introduce the panelists will discuss this in far greater detail, but obviously we know that death rates due to COVID-19 are highest among Black people and Indigenous people. Communities of color shares of deaths and share of cases consistently exceed their share of the total population. And we know these numbers are likely to be an undercount as we haven't been tracking the race or ethnicity of all Americans. And we know, of course, over 40 of the 50 largest clustered outbreaks in the USA have occurred in jails and prisons. The number of COVID-19 cases is 5.5 times higher among populations who are incarcerated. This is what we'll be discussing. Racial disparities in testing and case rates remain a huge problem, again, because of how data is reported or not. And of course, quickly, the situation is also dire in immigration detention centers. The coronavirus rate among immigrants in ICE is 13 times the rate of the general population. So given the increased risk factors that will be discussed, why don't we or do we have these populations as high priority for vaccine distribution? Let me tell you let me describe the fabulous folks we have to discuss this today. First of all, we'll hear from Professor Robert Fullilove, who is the Associate Dean for Community and Minority Affairs. He is a professor in Sociomedical Sciences and co-director of the city's research group. He's, of course, authored so many articles in the area of minority health. He's been on the Board of Health Promotion and Disease Prevention at IOM, at the National Academy of Sciences. He has a vast resume in all of these different issues. In 1998, he was appointed to the Advisory Committee on HIV and STD Prevention at the CDC. He became the committee's co-chair in 2000. Anyway, most relevant to this conversation, Dr. Fullilove is actually super involved with teaching public health courses in 6 New York State prisons that are part of the Bard College Prison Initiative, and he will talk about that, hopefully, if we're lucky. Moving on to Dr. Grace Lee is a professor of pediatrics at Stanford University School of Medicine and Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health. In her current role, she primarily serves as a clinical and administrative leader for the health system. She previously served as the principal investigator of the CDC-funded Vaccine Safety Data Link Project, associate director of the FDA-funded Mini Sentinel Project, The kind of qualifications here go on and on. And so I'm going to actually move on to Bruce Western, who is the Bryce Professor of Sociology and Social Justice and co-director of the Justice Lab at Columbia. His research looks at causes, scope, and consequences of U.S. prison population's growth. He's currently doing a randomized experiment assessing the effects of criminal justice fines and fees on misdemeanor defendants in Oklahoma City, and a field study on solitary confinement in Pennsylvania state prisons. He has also a ton of relevant experience. We're very, very lucky to have him. And next to Dr. Yang is Senior Vice President for Correctional Health Services, a division of New York City Health and Hospitals that provides medical, mental health, nursing, substance use treatment, dental health services, social services, discharge planning, and reentry support services to individuals in the New York City jail system. It's an essential partner in the city's efforts to reform the criminal justice system. She served previously as the Director of Health Policy in the Office of the New York City Mayor, Executive Deputy Commissioner of Health and Chief Operating Officer for the New York City Department of Health and Mental Hygiene. Also, lots and lots of accomplishments that are completely relevant to our discussion today. And of course, last but not least, we have our moderator, Chelsea Clinton, who is Vice Chair of the Clinton Foundation, a Professor of Health Policy and Management, and cooperating faculty with the Global Health Justice and Governance program. She focuses on promoting early brain and language development through the Too Small to Fail initiative and uplifting women, female entrepreneurs and women-led businesses around the world through the Caribbean-focused Women in Renewable Energy Network. And as we all know, she does many, many things, including writing great children's books. So Chelsea, over to you. And thank you all for being here. And thank you, all of you who are tuning in, and you're in for a great discussion.
Well, Terry, thank you to you and to the entire Population and Family Health Department for helping organize us. I know while we might be 6 boxes on the screen, there were many more people who worked to ensure that we could kind of be in virtual space and community together today. So I just want to start with recognizing that and gratitude to all who made today possible. We're going to hear from each of our distinguished panelists before we move into a moderated discussion. We also are quite eager to hear from all of you who are joining us today. So please use the Q&A function. Please, as questions occur to you, register them so that you don't forget them. And so hopefully we can kind of bank them for when we move to the audience Q&A portion of our time together. We're going to start by hearing from our Mailman colleague, Dr. Fullilove, to help provide some historical context and personal reflections, and then we'll move to our other panelists. So Bob, over to you.
Thank you so much. Really honored to be here, and especially honored to hopefully add a historical context to much of what we're going to be talking about today as we try to put mass incarceration into some sort of context that'll help us understand the threat to the nation, not just to incarcerated populations, that COVID-19 represents. Mass incarceration was sold in the 1970s, not as mass incarceration, but as an effort to control rising rates of drug use in inner city communities in the United States. Richard Nixon was very clear when he named drugs as public enemy number one, that the response to that crisis would not be that medicine and public health would be engaged in issues related to addiction and addiction treatment. No, instead, he wanted to make sure that the nation was aware that the problems of crime would be managed by the cops and by the police. And by 1980, a substantial portion of the prison population in states in the United States were folk who were locked up because of drug-related convictions. Really important to understand that mass incarceration was not an effective way of dealing with the problems of crime. It has a much more distinguished history, if you will, as a method of social control. It has its origins in slavery. The 13th Amendment, as many of you know, not only ended slavery, it also had as one really important proviso that an exception would be made for those who were duly convicted by the courts of having committed a crime. In the South of the United States, the labor that had been formerly provided by enslaved Africans was now made up in many instances by having folk arrested for crimes such as loitering or vagrancy, who would then serve on chain gangs and would do a substantial amount of the work that kept the Southern Confederate states and their economies more or less in the game. It's really important to understand that the result of that has been that since the 1970s, as many of you know, the United States, which has approximately 5% of the world's population, has been home to 25% of the incarcerated populations in the world. It's important to understand that roughly 60% of that population is represented by Black and brown folk. Blacks and Latinx populations are a substantial portion of what you see in a state like New York, where perhaps 85% of the imprisoned population are folk who are not only Black and brown, they are largely from a city like New York. What we're looking at in many instances is not just our notions about crime and punishment. We're also looking at the history of segregation in the United States. The red line districts of the 1930s that were created by the Homeowners Loan Corporation as a way of helping banks figure out where in the Great Depression to invest in cities was basically the way in which segregation in urban areas in the United States would be created. Red line districts created in the 1930s in all too many cities in the United States are the places where you're going to see the heaviest segregation and the heaviest concentration of poor communities of color, poor folk of color. Redlining not only establishes, amongst other things, where you're most likely to find high concentrations of poverty, they're also the places that are associated with high rates of crime, one of the inevitable consequences of poverty in the United States. Modern policing has made it clear the most effective way of deploying police forces is typically to send them into the areas where you're going to have the highest concentration of crimes. That is why police forces that have as mottos things like protect and serve are much more likely to be observers and folk who maintain the nature of segregation in American society by making sure that any crime that's committed in the street of a red-lined segregated area is a crime that will be punished by time in a jail and unhappily, in all too many instances, time that will be spent in a prison. It's important to understand how much urban areas like what you have here in New York City contribute substantially to the prison populations that exist upstate. Or to use a metaphor that's common here in New York, where New York City is downstate and New York City is upstate, in a substantial number of places in the United States, wherever you're going to have an urban population, you will have a rural prison that is largely the home of so many of the urban residents of areas that are unfortunately targeted by the police with a high level of police surveillance. Nowhere, I think, is this plainer than in the relationship between the state prison population in New York and the city of New York. The late Eddie Ellis, who was one of my mentors and one of the folk who talked most about the role that crime and punishment plays in the life of politics here in New York, did a study in the 1990s with fellow incarcerated persons at Greenhaven State Correctional Facility that demonstrated that in 1992, 75% of the state prison population came from 7 neighborhoods in New York City. Nowhere is the relationship between the police, redlining, segregation, crime and punishment, and the relationships between jails on the one hand and prisons on the others. Nowhere is it more visible than I think what you see in the state of New York. It's important to understand too, because many people sort of confuse the relationship between a jail on the one hand and a prison on the other. Jail is the temporary facility where you will be before you are tried. In 2017, it turns out that 11 million American citizens did time in a jail somewhere in this country. On any given day, an average of about 700,000 people are going to be somewhere in a jail facility. Every week, roughly 54% of that population is going to circulate from the jail into the community. And it is very clear that that circulation is part of what makes COVID-19 so deadly. The fact that you have folk going in and out of a congregate setting where COVID-19 is going to be easily spread has meant that you're not just looking at what is happening to an incarcerated population, you're also looking at what happens to the staff as well. The same is true of prisons. So this whole notion that what we have are institutions that might be out of sight is also the case that they are not out of mind. The virus does not care about the distance that might exist between one facility and a community of color. But the fact remains that this circulation means that the virus has all too many ways of making sure that what happens in a congregate setting like a jail or a prison will impact the health of the communities to which folk return. Seth Prinz, who is here on the Faculty of Sociomedical Sciences and Epidemiology, and colleagues have done a number of studies that indicate that infectious disease rates in prison have an enormous impact on infectious disease rates in the communities to which incarcerated persons return. This separation between prisons on the one hand and the community on the other, from a public health standpoint, is a false separation. In teaching for the last 11 years in the Barred Prison Initiative, I have a lot of contact with folk who are still behind bars, and their connections with BPI-LUM have made it clear that in the state of New York, we have a major problem. The idea that you have a governor who's much more interested in making sure that prison staff are protected, but who somehow feels that if you committed a crime, you're not worthy of protection by the state, has meant that in all too many instances, we're very slow to do what we need to do in our state prisons to keep communities safe. Happily, Dr. Yang, who's going to be speaking to you presently, and who, by the way, is a Mailman graduate, is someone who's done an enormously important job of making sure that the jails here in New York City are much more likely to be aligned with public health principles as we struggle to control this pandemic. The anecdotal reports I get suggest that we are having a difficult time. It is the hope of this seminar to not only alert those of you who are watching to the realities of prisons and COVID-19, it's also a hope that those of you who are vocal in your efforts to support public health will be vocal in your efforts to make sure that departments of corrections and state governors understand that there's a real peril here that they are uniquely positioned to address. It is the hope of public health that one way or other, the equalization of access to health resources will also mean equalization of access to those things that keep us all protected. How about I stop there? Thank you very much, and on to the rest of the panel.
Thank you so much, Bob. Although you acknowledged Dr. Yang, I think we're going to next go to Dr. Lee to talk about kind of the advisory committee on immunization practices and kind of the decisions that were made there on what the recommendations and the guidelines should be for the distribution of the COVID-19 vaccine to people who are incarcerated, and kind of how and why it reached the conclusions that they did, and also kind of what fairly significant variation we're seeing across the country and how those recommendations are being interpreted and operationalized. So Grace, over to you.
Thanks so much. So I'll just, maybe give a brief overview on the Advisory Committee on Immunization Practices. This is a federal advisory committee that recommends use of the vaccine in the US population. And these recommendations are given to the director of the CDC. Over the course of the and I'll just say, typically we are thinking about childhood, adolescent, and adult immunization, and obviously COVID vaccines. Although we've held to the same process and the same transparent process, since it is a federal advisory committee, all of our meetings are open to the public. One of the challenges obviously has been both timeliness of decision-making, as well as ensuring that we can think about how to allocate efficiently and equitably with regard to vaccine supply. So as many of you know, there are 2 mRNA COVID-19 vaccines that have received FDA emergency use authorization, and both with incredible efficacy and safety profiles. There is a 3rd vaccine that is coming this week to the FDA VRBPAC committee and the ACIP for further consideration. One of the things early on we recognized was that in the early days, we knew that there would be insufficient supply, and that it was important to consider an ethical framework for decision-making. As a committee, we reviewed various frameworks that are put out by institutions, including the National Academies of Medicine, and specifically settled on these 4 principles. First, to maximize benefits and minimize harms. And as was noted previously, we know that this COVID pandemic, the burden of disease and the burden of severe illness has been disproportionately borne by communities of color, lower wage workers, and vulnerable populations. For example, incarcerated populations and long-term care facility residents, as an example. Second, to promote justice as an important principle. And this is in particular, thinking about how important implementation is with regard to ensuring fair access to vaccines and equitable access to vaccines, and perhaps equity and not necessarily equal. The third being mitigating health inequities as a core component of the decision-making, and the fourth being transparency. As was mentioned previously, correctional and detention facilities are frequent sites of COVID-19 outbreaks. The COVID data tracker that CDC publishes, which likely underreports infection, as was previously noted, to date has identified 482,000 cases in total, 82% amongst residents in correctional facilities and 18% among staff. And most of those cases have been reported to date in California, Texas, Michigan, and Florida. Amongst those deaths, 95% occur in residents and 5% among staff. So clearly, again, disproportionate burden borne by residents of correctional facilities. ACIP recommended frontline essential workers be part of phase 1B for vaccination as part of the frontline essential workforce. So including specifically correctional workers. But early on, our state public health colleagues recognized the challenges with feasibility and implementation were important to address. And specifically, I'll give the example of long-term care facilities, where initially healthcare workers from long-term care facilities were identified in phase 1A for vaccination. But our state public health colleagues actually said, hey, it's really difficult for us to get out to some of these facilities to vaccinate staff and then to go back later and to vaccinate residents. Wouldn't it make more sense for us to vaccinate both staff and residents in long-term care facilities at the same time, rather than asking our public health system to try and support vaccination at different times? And similar to some of those feasibility issues noted with long-term care facilities, ACIP considered vaccination of staff and residents of correctional facilities at the same time, given the shared elevated risk populations in correctional facilities, including both staff and residents, the high prevalence of high-risk medical condition amongst residents, outbreaks that were documented in correctional facilities that could seed community outbreaks, as Dr. Fullilove mentioned, and the challenging and resource intensive efforts needed to vaccinate different populations in the same facility at different times. That said, as you know, throughout the last couple of months, there has been variability, substantial variability in how jurisdictions prioritize people in correctional settings, and that variability is significant. While we recognize that decision-making has to be local to a certain extent, and that data should drive that prioritization on a local level, regardless of the data, the variability continues to exist. And so I'll just point to a couple of examples. So I mentioned California, Texas, Florida, and Michigan as being populations who have the highest risk of infection, or at least high rates of infection in correctional facilities. I will say I'm glad to state that in California, actually, there has been attention and effort to ensure that individuals in congregate settings, including correctional facilities, both staff and residents, be vaccinated. And actually, the efforts have been very intentional, with actually the majority of staff being vaccinated in the state of California, and a high proportion of residents, not high enough, obviously, because we haven't had sufficient vaccine supply for the entire state of California, but actually higher than the general population at this point. In contrast, in Michigan, at least the current plans state that frontline essential workers, including corrections staff, be the focus of vaccination, not necessarily the residents. And then in stark contrast, in Texas and Florida, there is no mention in the plan specifically with regard to correctional workers or staff or residents. So, and again, recognizing these plans shift on a daily basis. So as many of you know, what is true today won't be true tomorrow. So it is entirely possible on the at a very local level, much of this is happening, but at least in terms of being explicit and transparent about the planning and decision-making, I do think that, as Dr. Fullilove mentioned, there is opportunity for us to be able to advocate for populations who don't always have a voice. Other challenges I'll just mention briefly include, and specific to correctional settings, but actually specific to all settings where we're delivering vaccines, are the variability in the capacity of medical teams to be able to deliver vaccines, the cold chain and storage requirements, which continue to evolve, vaccine acceptability being a major issue, and then the need to coordinate 2-dose vaccination, although we are hopeful that 1-dose vaccines will become available in the near future. And that I want to mention that strong partnership between public health and correctional facility staff and residents is critical to ensure access. Again, that strong voice is needed for underserved populations, and acceptability in that local champions really are needed to improve vaccine confidence. So it is often not physicians who are speaking about the vaccines who are going to inspire that confidence necessarily, but really the people who are there, who are the local leaders in those institutions, who are going to inspire that confidence. And our hope is that if we can keep 2 metrics in view, that being efficiency and equity, that we hold ourselves accountable to, that we can achieve sort of the outcomes that we had intended to achieve from the very beginning. Thank you.
Thank you, Dr. Lee. Since you gave us a kind of national perspective of the ACAP recommendations and intentions, and then kind of how those are being interpreted in kind of various ways from California, Michigan, Texas, and Florida, or perhaps not being interpreted at all in Texas and Florida's example. I think now, since we are a New York City-based institution, it would be really helpful to kind of hear from Dr. Yang, kind of from her perspective as to how these recommendations are being interpreted and kind of operationalized, here in New York City, and kind of what are your experiences and strategies to help vaccinate, and hopefully help vaccinate quickly, thinking about both equity and efficiency, people who are incarcerated here in New York City.
Sure, thank you. Just take a moment first to explain what we are, who we are. Correctional Health Services, or CHS, we became the direct providers of healthcare to people in custody of the city in 2016. We're part of New York City Health and Hospitals, which is the country's largest municipal healthcare system. We were back in March and April in particular, we were, if not the epicenter, we were certainly a focal point within the epicenter that was New York City. We did not have vaccine then, and there were 3 approaches that we really took to try and protect people from SARS-CoV-2 back in the spring, the first wave. I'm just going to basically touch on that. One was to maintain access to essential healthcare and basic healthcare that they need. As Dr. Fullilove mentioned, our patient population bears a disproportionate burden of disease, both chronic, underlying, and communicable. And so, we provide medical, nursing, mental health, substance use, social work, dental, medical specialties, discharge planning and reentry support in 10 jails, 8 of which are on Rikers Island, where we do free arraignment screening in all 5 boroughs at central booking. And we also run 4 court competency clinics. Our average daily population right now is about 5,400. That's back up to pre-pandemic levels, and I'll talk about that in a bit. 92% of our patients are male. 53% self-report as non-Hispanic Black, and 32% as Hispanic. The mean age of our patient population is 36 years of age, and the median sort of length of stay is 45 days currently. So really making sure that people still had access to mental health and medical care and physical health care during the epidemic was critical to help them ward off the virus, or certainly more severe course of disease. The second major tool we exercised was decarceration. We've since 2016 had a compassionate release program, and we really accelerated that and focused on COVID-related underlying risks during the spring. Since March, we've advocated for more than 3,000 people to be released, including almost 2,000 since just December, in anticipation of the second wave. 55% of our patients whom we advocated for decarceration or release have been in fact released. That was really critical in terms of depopulating the congregate carceral setting and getting people basically out of harm's way, and also to the benefit of people who remain behind in custody. Our third strategy was really containment, and back then it was really housing and testing and screening. And for those people who we couldn't get released, we needed to try and protect them as much as we could. One key strategy was housing, which is really I think as Dr. Fullilove mentioned, there's a lot of movement within shared spaces and among shared spaces to minimize patient movement between housing areas. And we created with the Department of Corrections an entire spectrum of new designated housing according to where you are in the COVID spectrum. So we separately cohorted people who are most vulnerable to a severe course of disease if they had contracted the virus. And then separately set people who are asymptomatic but with a known exposure housed together, separately from people who are symptomatic and known to be exposed, but their test results were pending, and separately for people who are confirmed to be COVID positive. By separating people and minimizing exposures and movement and opportunities for transmission was housing. All new admissions are also cohorted together for a period of time for quarantine and testing for, again, with Dr. Fullilove, people are coming in from the community, not just staff, but newly admitted patients are potential vectors in carrying the disease. The second thing that we did under containment back in the spring was testing and screening. We screen at every point of contact in the criminal justice system, so it's everybody at pre-arraignment, admission, at every clinical encounter, and on discharge. I should mention that, I'd say the majority of our patients are pretrial detainees. This is getting to the point of what Dr. Fullilove was talking about. So there's a lot of movement and uncertainty in terms of how long you'll be in custody. We test all new admissions regardless of their symptoms. We also test people for surveillance purposes, for contact information and investigation, and if a patient requests to be tested. Our strategy is always aligned with federal and state and city public health guidance, and it's been very much informed by the local epidemiology at the time in our jails. On island, we offer free testing for DOC staff and our staff. Again, people are coming back and forth from the community, from home into work, and we screen all staff and contractors before the beginning of any tour. Our 7-day average positivity currently today is 3.4%, which is less than half of what it is in the rest of the city of New York, 7.31. And I think that speaks to our containment, our screening, and our testing strategies. Really try and contain. It's inevitable that we have virus on island or in the system, but to try and mitigate that transmission and spread. Our total number of patients today with active infection is 58. But now, the newest and most game-changing armament in our containment strategy, and it has really been vaccines. On December 28th, we began offering vaccine to our staff, as healthcare workers. And on January 12th, the day after the governor announced 1B, we started offering vaccine to our colleagues at DOC, at the Department of Correction. On January 6th, CHS in New York City actually became the first correctional facility, and still I think the only jail in New York State that is offering vaccine to any patients at all. We were able to argue that successfully with the state, arguing that some of our highest risk patients were really clinically analogous to residents of community facilities that the governor had approved that are operated and overseen by the state health departments, such as nursing homes, or that are operated by Office of Mental Health, Hygiene, Mental Health, OMH, OPWDD, and OASAS. So we were successful and really delighted to be able to offer that. That counted for less than 10% of our population, though. Earlier this month, in February, the governor announced generally that people were eligible who were 75 years of age or older, or 65 years of age and older, and just last week, comorbidities. While people in custody were not explicitly included in his criteria, nor were they excluded. So in this case, unlike earlier in January when we needed to ask for permission, we just extended that to our patients because the state of custody was not a factor. So we've been able to offer that. Now that accounts for almost half of our population who's eligible. We have since last December, CHS has been advocating that everyone in custody should be able to be offered the vaccine, not because of a health or age condition, but due to the very nature of a congregate carceral setting. And we are very hopeful that we will soon get that approval from New York State. The acceptance by our patients varies widely. I don't think that's uncommon. Vaccine hesitancy weighing personal sense of risk of COVID. And, it's also the relationship with CHS, in terms of trusted relationships with us. They know who we are. We are the ones who take care of them all the time. It's also, I think, a dynamic of their peer groups and where they live. We do not consider a refusal to be a refusal. It's just a slow yes, where we continue to come back and give more information and talk through some hesitancy, some fears, and misinformation. And we intend to keep doing that so we can get as many people vaccinated as possible. And I think I'll stop there.
Thank you so much, Dr. Yang. Dr. Western, hopefully we can hear from you kind of broader reflections on just the context of COVID-19 and the different incarcerated settings that you study. And also, since decarceration has come up a few times as a mitigation strategy, if you could kind of offer some specific thoughts there. Thank you.
Sure. Thanks, Chelsea, and thanks to Terry for inviting me to be part of this conversation as well. And I'm blown away by the expertise on this panel. I come to this topic as a sociologist, not a physician or a public health expert, and as someone who studies mass incarceration. And I found Bob's introductory remarks to be enormously helpful for providing context for the pandemic inside prisons and jails. I think we can lose sight of the fact how unusual incarceration in the United States is, and it's historically unusual too. We only have to go back 3 or 4 decades to find a time when prison and jail were not pervasive experiences in the lives, particularly of African-American men with low levels of schooling. And that's the reality that we're living in now. Prisons are punitive institutions. They're unusual among institutions in that way because they're not built primarily for the welfare of the people who are housed inside them. So they differ from a whole variety of other institutional settings. And so what does this mean? It means that they're often old, they're often overcrowded, they're often poorly ventilated, and they're often black boxes, not very transparent to public scrutiny. And all of these conditions, I think, create really serious challenges for managing the pandemic. As we heard from Bob, the reach of incarceration is concentrated in low-income communities of color, where people are already facing a very, very significant health burden. And the health of the incarcerated population, even before COVID, of course, was poor. There are high rates of heart disease, high rates of asthma, high rates of hypertension, all of which create particular vulnerabilities to COVID. So the pandemic hits in early 2020. It tears through prisons and jails. Terry spoke about how correctional facilities were regularly among the leading hotspots for outbreaks of infection. This was a context in which over the summer, the National Academies convened a panel looking specifically at the challenges of COVID in correctional facilities. And I was part of that panel, and the leading recommendation for that group was decarceration. We had to de-densify the institutions and get people out who were particularly vulnerable. And this really meant two things. This means diverting people at the front door, and there's a lot of gratuitous incarceration, I would say, in the criminal justice system, where people are detained because all of the defaults are set to a presumption of confinement. and that has to be reversed under the intense health challenges that the pandemic provides. And decarceration means getting people out at the back door. And really the only instrument for doing this is, or the main instrument for doing this potentially is compassionate release. But as one of our panelists said over the summer, the problem with compassionate release right now is that it's neither compassionate and it doesn't release anyone. And a lot of state statutes require people to be within 6 months of death and non-ambulatory. And under conditions of the pandemic, that's not an effective way for releasing people. So we need more. We need more scope for compassionate release, in which medical vulnerability can be weighed as a criteria for getting people out. The other part of this I want to mention, which hasn't come up yet, which I think is really important, and perhaps Patsy can speak to this too, because I think they've done an incredible job at Rikers of faced with a ferocious outbreak. They've managed to get their arms around that there. But another piece of this is re-entry. And it's one thing to reduce the scale of the population and try and manage the risk of the spread of infection inside of the facility. But there needs to be a plan for people on the outside so they can quarantine safely, so they can self-isolate safely. If people have received one shot inside the prison or the jail before being released, there needs to be adequate continuity of care. So the possibility of follow-up and the second shot is a reality for them. And because of the high health needs of the population, there are countless reasons for the importance of continuity of care from inside the institution to the community. The last thing I'll say before I stop was, the thing that impressed me in listening to the physicians and the public health experts is that there was no argument I could see for distinguishing in priority correctional staff from incarcerated people. Both faced very, very high risks of COVID inside correctional facilities. I see this happening a lot in policy positions around the states where correctional staff are classified as first responders and a given priority, but there's no public health argument for this priority. The risk for the two groups is the same. This goes to deeper issues that Bob put a historical perspective on that I hope we can get to in this discussion. Thanks very much.
Thank you, Bruce. And before we kind of broaden this discussion to kind of hone in on a few questions, Patsy, since kind of Bruce specifically kind of nodded to you with a question around kind of preparing incarcerated people for reentry, specifically with an eye toward continuity of care, and kind of especially kind of with the question around kind of how to ensure that if someone receives their first COVID-19 vaccination kind of while under your care, that they're able to receive their second on schedule once kind of they're back in the community. Could you, perhaps just respond to that? Thank you. Sure.
And I think another one of our alumna is probably listening in, and she actually runs the reentry service for us. On discharge, our goal is really universal discharge on day one, that the discharge planning begins day one, and that mostly focused on Medicaid and access to other benefits and services. Different from the Department of Corrections discharge and reentry support services, ours is really health focused. For example, in specific to COVID, we have if somebody's being discharged and they have need to isolate or quarantine and they don't have a place in which to do it, we arrange for them to have a hotel room where they can stay and get services there. We certainly work in coordination with the city's test and trace program so that they can continue to provide services to people after they're released. CHS created what we call the Point of Reentry and Transition program. And we have a port line that's staffed by people with lived experience who can answer questions from anywhere outside after release, whether it's for healthcare or insurance or benefits or referrals or anything. We also created 2 port practices within our sister health and hospital facilities at Kings County and Bellevue. And that not only includes community health workers who are also with lived experience and serve as patient navigators. They'll meet you on First Avenue and walk you through Bellevue. But CHS's own providers are rotating through and providing care there. So you can see the same provider who saw you outside. It's a service and a program that is very flexible. You don't need appointments. You can just walk in, it's flexible hours. So it's very much a more accessible, culturally accessible place. We have worked with our sister agencies, sister facilities at health and hospitals on second shots. This is a little bit complicated because people are still saying that you can't get a second Moderna if you got a first Pfizer. So that's just another little complication there. But we do have arrangements with people through port that we maintain contact with patients after they're released for their second appointment. We do on first shot, as we're required, give that little white card with the date of your second appointment. Our number, our port line is there so that you can call if you are released and we weren't able to connect with you before. Again, this is the transitional aspect of the jail versus the prison. You could get discharged or bailed out directly from court. We may not see you to call port, and we will arrange for you to get your second dose. The vaccination of patients has been relatively recent, but we're only sort of starting on the second dose of people, but we have managed to arrange second doses for people within the appropriate time frame who have been released since, and it's mainly through port.
Great, thank you. Bob, I think really a question prompted by kind of Bruce's almost closing comments, that it's encouraging to him that there's no real question as to what kind of the right answers are from a public health perspective. And yet clearly kind of through your decades of experience as an academic, as an advocate, as a teacher, so rarely, unfortunately, are decisions made kind of through a public health lens or from a public health perspective. Listening to this conversation, listening to kind of what, Dr. Yang has proven possible here in New York City, do you think that the COVID-19 experience will change the way that we think about, well, I would ask like mass incarceration generally, but also for people who are incarcerated, kind of why their healthcare needs should be prioritized, that truly kind of this is such a classic example of, none of us are safe until all of us are safe?
Yeah, I mean, I think you put your finger on the lesson of the pandemic, that the well-being of people who are facing the harshest life conditions, their well-being is intimately connected to the well-being of the entire community. Will we take that? Will we take that lesson? I think to the extent that we've learned from lessons like that in the past, it's largely been through a political process where communities have become organized and have advocated for the well-being of the most disadvantaged members. So I think it's an open question. The pandemic has created a political opening, and now I think it's the job of advocacy, of research, and so on to take advantage of the opportunity. The one thing I would say, and I'm always impressed by the physicians on this panel. I think the key difference between criminal justice and health is that criminal justice in its fundamental nature is a blaming institution. It assigns blame, and health and health policy, in its nature, when it's done right, and we can talk about when it's not always done right, but when it's done right, is a non-blaming intervention. People are patients in need of help, and I think that's the key intellectual shift that a politics has to capitalize upon if we can reframe this whole problem from crime to health.
Yeah, Patsy and Bob.
Yeah. I was just going to say, I agree totally about political, but let us not forget about the legal arm and going to courts. I mean, there are some key yardsticks here. Estelle, v. Gamble, a few years, decades ago, about establishing healthcare basically as a constitutional right. More recently, just this past month, actually early February, there was a lawsuit filed by numerous defense agencies on behalf of two of our patients, based on the 14th Amendment and equal protection, specifically about access to COVID vaccine. So there's the political, there's the legal. I think they all sadly need to be turned to if not voluntarily offered.
I think more than anything else, there's a really fascinating, somewhat catch-22 to all this. If you are a reader of New York news, especially days, you might have noticed that there are a number of articles that deal with the mayoral election and the question of what will we do with the cops. Part of what was pointed out in one of the articles is that there's been a 47% increase in the number of murders in New York City over last year. There's been an almost 100% increase in the shootings that have occurred. Everybody wants to know, what are we going to do about it? Well, the police don't work on housing. They don't work on issues of mental health. They don't work to diffuse tensions in neighborhoods that often turn to violence. What they do is arrest people and send them to jail. So here we are in the midst of a pandemic where the last place you want to send somebody is to a congregate facility where you will increase the likelihood that disease in the community will be magnified by the circulation that we've all been describing this morning between the facility on the one hand and the community on the other. Of all the ways to sort of question the logic and the wisdom of mass incarceration, this pandemic might just be the most important factor. Now that we see that there are public health consequences to what we do in the name of social control, it would be interesting to see whether or not we dramatically increase healthcare capacities in jails and prisons, or whether we start thinking about the wisdom of maybe investing the money that we're spending on police in issues of housing, issues of mental health, issues of poverty, which are so much at the core of a lot of the crime that's committed, not just here in the United States, but worldwide. I think we are in interesting times, to say the least.
And Grace, since you've unmuted yourself, hope that means you're going to offer us your thoughts on the question too.
Thanks. I just wanted to follow up on Dr. Western's point, specifically around protecting those at highest risk of infection and the highest risk of severe disease. So while I feel strongly, perhaps maybe as a healthcare provider, that we need to be able to protect those who aren't always able to advocate or protect themselves as well as others, I will say that in each of the phases of allocation, we focus both on severe disease and risk of infection for the reasons mentioned. So for example, in phase 1A, we had originally talked about 75 and older and long-term care facility residents as those at the highest risk of severe disease, including hospitalization and mortality. And also those at highest risk of infection. And, I will say the healthcare workforce, and you could argue that we are very well protected in the healthcare delivery setting. But our frontline essential workers, I do want to make sure that I point that out, that it's a really important group that I feel like somehow that voice has gotten lost as people have focused on age-based approaches because of the simplicity. It is far easier to vaccinate based on age than it is based on occupation or risk per se. So many of the frontline essential workforce who actually are serving in our communities are being asked to serve so that we can put food on our table. And they don't often have the same level of protection as others. And I would say that is also the reason sort of, I would say it's exacerbated in congregate living facilities where, they're not offered full PPE to be able to protect themselves full time. And so the question is really about making sure that we are providing the full protection for those who might not have sort of equal access or equitable access to the same level of protection. That is in addition to what Dr. Fullilove mentioned, which is around the higher risk of infection and the impact on communities. While that might motivate us, I would hope that sort of we have a moral and ethical obligation to populations who don't have that voice and don't have the same level of ability to protect themselves. And so I do feel like it behooves us to ensure that we are doing ensuring that the protection is offered to those populations that need it.
Well, I certainly wish that were true, but unfortunately, I think we have many decades of that having not yet been sufficient, but maybe this moment will change that. And I think, Bob, did you want to share your screen to show us something, please? Feel free to do so.
And there it is. Yeah, this is from the state of California, hot off the press. The occupations with the highest relative death increase in mortality during the pandemic in her state, California. And what do you see at the top? Cooks. 60% increase in mortality based on what's happened with this pandemic. Yeah. And I think it's just really important to point out, this is also the population that is most likely to find themselves in a jail, most likely to struggle to make bail. Even $100 for folk who are in this category can be a real struggle. And the whole notion that, there's somehow this separation between people who commit a crime or who get arrested for a crime and people who are just sort of normal members of our population. Yeah, I think these are all distinctions that this pandemic is really making us rethink and revisit. From a public health standpoint, what you're looking at here is much more, what do we create in our society that is going to put people at risk for their health? And more than anything else, once again, the pandemic has highlighted this in really unusual and very critical ways.
Well, and I think, Bob, it's highlighted how little understanding we've had kind of as a body politic of where risk was distributed before the pandemic. I mean, I will say, just as exploiting my position as a moderator, it has been quite painful to me to kind of continually read or hear the framing of what the pandemic has revealed. Like, it has only revealed things if you weren't paying attention. And Terry, I know you wanted to offer a few thoughts.
Just very quickly, one of the things that really struck me always in the HIV world is when there was a national AIDS plan, when there was an AIDS czar in the White House, prisons and jails was not part of that. So I'm wondering, it sounds like the planning now is around COVID is we have moved forward in at least integrating somewhat, or have we not? That was my question.
Grace, perhaps you could kind of answer first from the kind of AKIP perspective, and then kind of Bruce, I see you have some thoughts, and probably everyone else does too, but perhaps Grace, we can start with you.
Well, I hope so. My hope is this changes everything. I will say that specifically for ACIP, equity as part of the decision-making framework and making that explicit instead of implicit is one thing that I think going forward will not change. I think the other component that actually has been really important for us is thinking about ensuring that diverse populations are included, for example, in clinical trials. To date, we really haven't had much diversity at all in clinical trials, whether that be by, high-risk medical condition, whether you're a frontline essential worker, whether you're by race, ethnicity. So all of those things I think have never really been considered until now. And I feel like COVID has put much of this at the forefront, made it clear and transparent. And I hope will forever change the way we think about decision-making and the importance of incorporating equity specifically in our recommendations. And with regard to incarcerated populations, there is specifically a task force within CDC that is dedicated to focusing on all underserved populations. And I think that's really important. In addition, I will say that we have seen more data on in the dashboards focused on equity than I've ever seen before. And I hope that we just continue to build upon that and that this becomes sort of the new way of business in a way. And I hope this, not only for all underserved populations, but just in the way we even deliver healthcare, because I think that it continues to remain inequitable in many ways. So if this is a fundamental and foundational shift, I think it's for the good.
Bruce?
Yeah. When we were doing our work on the National Academies panel over the summer, we heard from the 50 state correctional leaders of the state prison systems, and I thought there was a lot of variability across the states in the integration of DOCs and correctional healthcare into pandemic preparedness planning, and it because correctional healthcare is for the most part quite a siloed system, and it's really disconnected from the rest of the US healthcare system. And one consequence of that was that a lot of correctional healthcare providers weren't systematically integrated into pandemic preparedness planning that was going on at the state levels. And what it really took was for state DOC leaders to enlist public health expertise in the planning process. And some really jumped at that, and some did not. And I think, state prison systems, the whole mindset is around custody and not around health. And to enlist a different type of expertise is a bridge too far for a lot of correctional administrators.
Patsy, you want to offer something?
Yeah, just I think in most of the majority of circumstances, the health care is subservient to or reports to the sheriff, to custody. So custody obviously is paramount consideration. I think that's further exacerbated by when the custody agency contracts that out with a private healthcare provider. I think the ownership and leadership is very, very different in that regard.
Bob, do you want to offer kind of any thoughts too, just since you have both kind of worked with and worked in so many different incarcerated settings?
Just the degree to which, amongst other things, we live in a country that has 50 different countries as part of its makeup. So from one state to another, just because of the way states' rights operates in the American context, yeah, you're going to see huge variability. It's going to be impacted, for example, by the amount of money that is typically spent on public health in general, on public health agencies, and then, as Bruce has pointed out, how much departments of corrections are typically very, very separate and pose for those who are medical professionals the problems of dual loyalties. Where do you base your attentions on your need to do no harm and to care for the patient, or as a basically employee of docs, is your real allegiance to the superintendent, to the facility itself, and to making sure that their concerns about safety and security and everything else are taken care of? In too many instances, and you certainly hear about this as a cause for vaccine hesitancy on the part of folk who are incarcerated, a real concern that if you're going to give me a vaccine, please don't give it to the person who's running the healthcare facility here. I don't trust that guy. That's the person who will often sign the release that lets me go into the box, that will have me go into the SHU or what have you. No. I like the idea of a vaccine, but don't have a state employee who works for docs be the person who administers it. So a lot of what we have to do isn't just simply make vaccines available. Everybody, I think, has pointed out, vaccine hesitancy is a rational way to approach one's health if you're a person who's incarcerated and really worried about whether or not the people in the facility really do have your best interest at heart. It's a real tension, and it's something that has to be dealt with.
And Grace, since you were nodding, maybe you could offer some thoughts if ACIP kind of thought about the kind of specific issues of vaccine hesitancy, in congregate settings for incarcerated people, or did you not? But maybe you have personal kind of thoughts to provide here.
Well, I think we've focused, and many of the metrics that you see sort of published in media are specifically around efficiency. And while access is incredibly important, if we can't get access, that's a huge problem. But let's just take for granted that access is available. Then I think the acceptability question is huge, and we've talked a lot about this in terms of implementation. And at least in the general population, acceptability is not 100%. One of the things that I think still remains true, and actually I look to Dr. Yang and I'm appreciative of her efforts to be that trusted voice. So a lot of people still trust in their physician or their healthcare provider, whoever that may be. And so, at least if that recommendation is a strong recommendation coming from somebody who provides care to you in a time of need, I do think that voice continues to be a trusted voice. It's not sufficient though. So we really have looked to community leaders who may not be medical in any way, but are, again, the trusted folks in that institution. So it might be Dr. Fullilove, for example, as he's lecturing in various institutions. It might be different folks who are actually providing that trusted recommendation, but engaging in leaders in the community, whichever community it is going to be critical and important to making sure that message gets across. Because I think without that trust, as was mentioned, it'll never happen. The other thing I just want to mention briefly is just, we talked briefly about equity and decision-making at the national level, but as you can tell, everything is about implementation. So if it's not built in or baked into implementation, and again, if we don't measure how well we're doing, it won't happen. So we can have these lofty ideals and goals and recommendations, but it's really the people on the ground can make the difference.
And before we move to kind of audience Q&A, Dr. Yang, I just want to give you the chance to comment not only on the conversation, but kind of to share kind of what specifically you are doing to try to be patient, as you kind of spoke about earlier, and to really ameliorate kind of what hesitancy you may be hearing, from your patients.
Yeah, I don't think it's all that different. There's a distrust about Operation Warp Speed and whether COVID's real or not, and what's in that vaccine, and is that really, did that come from that vial? All understandable and to be respected, right? We're talking about people who already are in an environment where they have lost so much of their own agency that we want them to have as much information and good information as possible, which is why we keep going back. We talked to our chief medical officer last week, did a call to action for everybody in the clinics and clinical encounters to talk to every single one of their patients at every encounter about the vaccine. It really does seem to be, it's a face-to-face issue. We certainly have material, we have written material, we have flyers. Two of the correctional officers who were with us in our vaccination teams, where we're now at a point where we're going house to house, housing unit to housing unit, and calling people who we know are eligible, but also people who may not be initially eligible. We're asking for their names, and we'll find them when they are eligible, which we hope is pretty soon. But it is continue to go back each time, and when we're going to a housing area and giving second doses, that's an opportunity again to talk to everybody about a first dose. Where people consent, we will vaccinate them right away. This is a different phase than the earlier phase in January, where again the clinically analogous folks who are residents in nursing homes and places like that. We in the city system, we created therapeutic housing areas where correctional health services, more than DOC, decides that you are eligible for this housing decision, and security is a secondary consideration, right? Your own individual clinical needs are first. Our staff are actually in those units. We're embedded in there, so we are a much better known entity to those patients. In terms of efficiency, it was always also there. Everybody was cohorted. Everybody who was in that house was eligible. We didn't have to go picking and choosing. What's happening now with the underlying is you can have people, and the dynamic in house can be very, very much changed. Whoever is sort of the social leader in that housing area is pretty much could help encourage people to do it, or could pretty quickly squelch somebody who might be the one or two people who come forward to the gate and want the vaccine, they can easily, very quickly be deterred from doing that. So we just keep going back and hope that when we can offer it to everybody, that can help tip the balance on a particular unit where everybody can come. I think if everybody who watches people who have been vaccinated, they're looking for what side effects. They're making sure that we're all still standing and breathing. And I think that again feeds into the slow yes and the repeated one-on-one conversations, whether it's in clinic or in a housing area or in any other point of contact with our patients.
Thank you. I want to be mindful that we've got quite a few questions from our audience, and I'm going to ask the one that is kind of a direct segue from our last discussion on vaccine hesitancy, which is from someone who asks, some states, such as North Carolina, are offering a small reduction to a person's sentence in exchange for getting vaccinated. What are your thoughts on this? Bruce, do you want to go first because you're unmuted? I'm going to call on you first.
Yeah. I was just looking for the question in the box. It sounds good to me. I mean, I think I think there's evidence that shows that small sentence reductions. The implications for them, there aren't significant implications for public safety, but there could be very significant positive implications for public health. And so, that seems like a good trade-off to me, particularly in a context which people have a lot of hesitancy. Well, I've got the floor. I would love to sort of throw something out. And one thing I've been thinking about a lot is credible messenger anti-violence programs in which justice-involved people are often, conveying messages to people at highest risks of victimization, criminal victimization. Is there any role for justice-involved people in getting past vaccine hesitancy and as sort of trusted actors who might be working in prisons or jails? I don't want to crowd out time from the questions, but I was just incredibly curious as to what our experts might think.
Yeah, I mean, Bob or Dr. Yan.
A couple of thoughts. First, no good deed goes unpunished. I worry that, this will have short-term impact, but I think what's going to be much more interesting will be the reactions of political pundits. Governors are frightened to death that by giving a vaccine to the perpetrator of a crime and not giving it appropriately to victims of crime, just to describe one of the ways in which this is often articulated. It'll be interesting to see whether a solid public health message that can increase rates of vaccination will not come back to haunt somebody politically. And I'm in complete agreement with Bruce. We've trained a substantial number of folk who have taken public health courses in prisons to come out and specifically work in the communities to which they'll return on everything from preventing youth violence to being heavily engaged in other kinds of efforts to spread the public health word. It's really interesting to see how many people who are from the HIV world are now engaged in doing COVID-19 work, including in the state of New York, people who were involved in a program sponsored by PACE, the prisoners concerned about AIDS counseling and education, who have now developed an incredible rapport and an incredible public health expertise that I'm hoping the state will use to provide the kind of credible messengers about a variety of things. COVID-19 on the inside, and returning to the community as credible messengers who can help us deal with some of the rises in violence that have been associated with the pandemic. I think it's all bound up together. It's a notion of how are we as a nation going to regard incarcerated populations and the policies and programs that put them there in the first place. Just the idea that this might be an occasion for the nation to press the reset button, I think is at the core of much of the comments that we have on this panel offered during the time that we spent together here today.
just what Bob was talking about in terms of the political pundits and everything made me think one other thing, which is, we have been working very hard to get people to sort of intensify our decarceration, our compassionate release efforts. And the arguments really have been the increased risk based on physical health and mental health conditions due to COVID. There is possibly the thinking also that the strong desire on the part of some to know how many of our patients have been vaccinated argues against their release. They've been vaccinated. They're okay. They can stay locked up, right? So there's that, the two sides of the coin, I think that you were talking about. No good deed goes unpunished. There's a downside to that as well. And I also want to say, that the increased risk is not just a physical one, but it's a mental health one. What we've seen has been the impact of, everybody has higher levels of stress, anxiety, particularly in the early phase, but, this is like a long drag out time, right? This one is not that tsunami that we had in the spring. This is a slow burn. And the court systems haven't really stood back up fully. So not only the anxiety of being locked up and being exposed and being in a shared environment where your food, everybody's close together, and the points of contact and touching and physical, the guards talk, the officers touch you, your food delivery comes from somebody else who's touching your tray, all of that stuff happens. But you, as a pre-trial detainee, don't know when your court date is because the courts aren't fully functioning yet. So your purgatory is even extended. You have no idea when your case will be heard and resolved. Visitation restrictions make you even more isolated. And so I don't know where I'm going on about this, but anything that stops the point for alternatives to incarceration and release where warranted to be safely done is a problem. And actually, I think vaccination is being used, thought of, and contemplated as one reason to keep people in. Ironically,
that's the most horrifying thing I've heard recently, an infuriating thing that I've heard recently, and I'm so stunned, and yet I shouldn't be, because of course there are people who are making that argument. One of the kind of real threads looking at all the questions that we've gotten, and we've now gotten lots of questions, is people who want to understand kind of the different dynamics that are in play, kind of to Bob's point of, we live, in the United States of America, but arguably not only 50 states, Bob, but also plus, Puerto Rico, Guam, and kind of all of the various territories. For students or others who may be listening, what resources would any of the panelists direct them to if they want to understand kind of how the kind of incarcerated system in their various kind of states or territories is organized? Who is in charge of healthcare? Kind of, I think people really want to know, where do they direct their frustrations, or where do they direct their advocacy if it is kind of such an idiosyncratic reality in so many different places because of kind of how the incarcerated system, may be organized, may be governed, may be regulated, whether or not, to kind of Dr. Yang's point, kind of there is kind of separate publicly provided healthcare, or whether it's private contractors, or whether it's totally subordinate kind of to the warden. Bob, I don't know if you're looking to unmute, but there are just so many questions from different people who are like, how do I even know what the reality is in my county or my state? So I know we have vanishing minutes, but I think those questions are really worth answering.
Lots of resources on the web. The Sentencing Project, which is the Sentencing Project, oneword.org. The Brennan Center here in New York, which does an enormously effective job of monitoring COVID-19 in all the states with respect to systems of incarceration. It's a serious source of, I think, important information. And the Kaiser Family Foundation traditionally does an absolutely magnificent job of looking at COVID-19 in communities of color, where, as we've been describing here today, folk who are incarcerated represent an important subset of that population. So those are all available on the web. Thank God, in the age of Google, being informed is relatively easy. And it basically says, if you're interested in this, all you have to do is look, because you will find.
And Patsy, I don't know if you were looking to unmute, but if you have kind of specific thoughts for kind of, again, since we are a New York-based institution, New York City-based institution, proudly, Terry, if people have questions kind of, related to New York City or New York State, if you want to offer kind of other specific thoughts, I think that would be great.
No, not really. I mean, the state system is so different. The state is a prison system, and it is run, and the health service is under the custody operation. I think we're fairly unique. We have a website. We have, you can go, as Dr. Bob said, just Google us, and you'll find information about us. And you can send questions to us as well that way.
And another set of questions, and forgive my now rush tone, but I'm mindful that we have 8 minutes left. A couple of people ask questions, somewhat related to, our incarcerated populations themselves being kind of brought into planning on any dimension of COVID. Some people are asking about testing. Some people are asking about kind of, vaccine campaigns kind of within incarcerated settings. I don't know, Bob or Dr. Lee or Dr. Western, if you have kind of broader thoughts, or, Dr. Gang, if you can talk about how your patients have been able, or maybe have not been able to kind of be part of either the planning or the communication of the plans.
Yeah, first off, there are a substantial number of folk who are formerly incarcerated, returning citizens, who are in a variety of different think tanks that are actively engaged in this. There's the Fortune Society, which is based here in New York City. There's the Center for New Leadership, which is in Brooklyn. I mentioned Eddie Ellis. This is an organization he founded for his death that has done an incredible amount. It is a think tank of formerly incarcerated persons. There's RAP, Release Aging Persons from Prisons, which has been doing an enormous amount to sort of alert the general population to what's going on here in the state. And I think, once again, you'll discover that formerly incarcerated folk are doing a wonderful job of organizing, becoming politically conscious, engaging in all kinds of political campaigns. And they are, I think, one of the trusted sources for information about what's really going on. And once again, if you look for them, Google will make it easy for them to be found.
Bruce, you're nodding. Yes, do you want
to? Just to add to Bob's list, Deanna Hoskins, who is head of Just Leadership USA, which is all about political training and empowerment for formerly incarcerated people. She sat on the National Academy's panel on COVID in prison, and she's part of an R01 application now for a vaccine hesitancy program. So JAL USA are doing great work in this area.
And Bruce, maybe explain what an R01 is for people who might not.
The NIH research grant.
Thank you. Terry and I did a previous panel where one of the main comments we got back was that we all use too many acronyms. So I'm trying to myself kind of be learning as we do. As we do more of these. Bob, we've also gotten a few questions, and I think this is really kind of for you first, and then of course for anyone else who wants to comment, as to whether or not kind of the racial makeup of various incarcerated settings can be correlated to the quality of healthcare that incarcerated people receive within them. I think we got at least 3 questions that are kind of in that subject area.
Sure. If I didn't make it explicit, the answer is, of course, absolutely. So first and foremost, people come from communities where health disparities are rampant. So the idea that you're basically seeding your jail and prison populations from unhealthy communities means that the challenge for healthcare on the inside is really, really that much more prominent. And then people get out of prison typically in worse shape than was the case when they went in. So again, just sort of thinking about the cyclical nature of all this, that one is part of a system that influences the other parts of the system, cannot be overlooked. So our nation's legacy of health disparities is, of course, something that you're going to find really overrepresented in what you're going to see with incarcerated populations. And I think the fact that these have become places where Americans feel content to say, that's not me, they're not any of my tribe, so I don't have to pay attention to them, means that there's no real public pressure to make sure that incarcerated populations get the health care they deserve. We're from a nation that really believes you shouldn't coddle prisoners. And the minute you start thinking that coddling a prisoner means that you have to deny them health care, you're not surprised that in places like Mississippi or Alabama, what you're going to get on the inside is nothing less than horrible. So yeah, they're definitely related.
You know, just in our final few minutes before we turn to Terry to close, we received a lot of questions that circle back to kind of an earlier part of our conversation, which really are kind of students, and I'm sure, you know, some non-students asking, you know, moving forward kind of through COVID-19 and afterward, you know, what can anyone listening do to try to ensure that incarcerated populations are not left out of the health equity conversation? And that if we really are going to have kind of more of an equity focus in our country, and really appreciate kind of what Dr. Lee said earlier of not confusing kind of equity and equality, how do we ensure that our incarcerated populations, whether those who are in prisons or the many hundreds of thousands of people, as Bob pointed out, who will cycle through our jail system every year, are included in the conversation? So Bob, maybe we can, you know, our Grace, please, you unmuted first, and then we can go kind of, you know, Grace, Bob, you know, Bruce, and I think we'll give the last word to Dr. Yang, if that's okay. So Grace, please.
Thanks. I'll try and be brief. You know, I very much believe that data should drive decision making. I realize that's not always true, but if you don't have the data, it's really hard to influence the decisions. So I think a laser focus on equity and measuring equity is going to be critical. I also will just say that I have been incredibly impressed with how advocacy efforts can make a huge difference at the state level. So I strongly encourage you to go and reach out to the influencers in your state to be able to learn how to make that difference. It really does change the decision-making about COVID-19 vaccines allocation. I've seen it from various communities, and depending on the state and depending on the strength of the voice of that particular community, it can make a difference. The last thing I'll just state is that I very much appreciate the question about engagement of you know, those who are being vaccinated. What are the values? What's the acceptability? And I know that there are specifically, at least in California, I know there are projects to look at vaccine acceptability, because it turns out the barriers may not be what we think them to be. And so understanding what they truly are will help us actually hopefully design better programs to ensure that we are not only providing, again, access, but getting it to people and making them feel comfortable that it's a safe and effective vaccine going forward. And our goal is to protect the health of everyone.
I just want to say that prisons in the United States create a permanent class of second-class citizens. The more we're aware of the fact that the inability to vote, the inability to get housing, the inability to get education is often hugely conditioned by whether or not you have a felony conviction on your record, means that in all of our efforts to expand the scope of civil rights and advocacy in the United States, we have to include incarcerated populations because they come from the groups that we say we really care about. Seeing their status as being something that deserves special attention for all of us who say we're advocates, it seems to me as public priority for all of us, number one.
Bruce?
Yeah, I agree strongly with Grace and Bob. And the one thing I would add for the students who are tuned in, I think that often in areas of public policy, researchers readily partner with government agencies, but they much less frequently partner with community representatives and community organizations. And there's a real importance and a real urgency to doing that now when it comes to the problem of mass incarceration and all of the issues in that orbit. And it's harder to do, and I think we don't have great models for it, but there's a tremendous appetite on the part of community organizations for high quality research. And I think for the students listening in, sort of seeking out those opportunities, Bob listed organizations in the New York area. I think seeking out those relationships could make a big difference.
And Dr. Yang?
I guess the only thing I would add is come join us. Correctional Health Services has a lot of people from, we're public health people by education and commitment. We do applied research and advocacy and great reforms, and we're, find purpose if not mission with us. So come on over.
Dr. Just to be clear for any of our MPH students, whilst clearly you have physicians, you also have, as you said, applied researchers and others. So you don't have to have gone to medical school. You could come with your MPH, I think, quite proudly to work with.
Yeah, we data, research, advocacy, systems, administrators, nurses, doctors, social workers, reentry, people with lived experience, anybody who, we're part of the larger criminal justice reform also, which is really moving to a different way. So, and you'll never find something that's more satisfying. There, that's my pitch.
I can't imagine a better note to end on. And I know we're a few minutes past time, but I want to thank all of our panelists so much, and thank all of you for joining us. And Terry, when I hand it over to you for our final word.
Hey, I don't have much more to add except to thank you, Chelsea, and thank Lizzie, Margaret, and Jenny who put this together. And thank you, amazing panelists. Clearly, if we talk about public health or preparedness, we cannot silo off prisons and jails. That's very clear. And we need a lot more accountability. That's also very clear. So thank you all. And it's snowing in New York City.
Again, winter just seems to not end in New York City.
Yes.
Thank you all so much for joining us. And please reach out to Dr. Yang if you'd like to join her. Thank you all. Stay safe.